The kidney, a vital organ, plays a crucial role in maintaining homeostasis. As we zoom in, we observe a healthy nephron and glomerulus, where blood enters through the afferent arteriole and flows through the glomerular capillaries. The normal filtration barrier, consisting of the endothelium, glomerular basement membrane, and podocytes, selectively filters plasma while retaining red blood cells and most proteins in circulation. This filtration process is essential for maintaining bodily fluid balance. However, in acute nephritic syndrome, an immune-mediated glomerular injury disrupts this process. Immune complexes or antibodies interact with the glomerulus, initiating a cascade of events. This leads to complement activation, the release of inflammatory mediators, and the recruitment of neutrophils and mononuclear cells to the glomerulus, resulting in marked swelling and inflammation. This state of immune-mediated glomerular inflammation is a hallmark of the disease. As the glomerulus becomes inflamed, the structural integrity of the filtration barrier is compromised. Inflammatory injury affects endothelial cells, the glomerular basement membrane, and podocytes, leading to increased permeability. Red blood cells begin to escape from the glomerular capillaries into Bowman's space, eventually entering the renal tubule. This leakage of RBCs represents glomerular capillary injury, ultimately causing hematuria. As we follow these red blood cells into the renal tubule, we observe their transformation into dysmorphic shapes as they traverse the damaged filtration barrier. These dysmorphic RBCs become trapped within a protein matrix, forming RBC casts. The presence of dysmorphic RBCs and RBC casts in the urine strongly indicates glomerular hematuria, a critical clinical manifestation of acute nephritic syndrome. Returning to the glomerulus, the impact of inflammation continues to reduce the glomerular filtration rate, or GFR. We witness endothelial swelling, inflammatory cell infiltration, endocapillary proliferation, and the narrowing of glomerular capillary lumens. As these changes progress, blood flow and filtration through the glomerulus diminish, leading to decreased urine formation and oliguria, a common feature of the syndrome. Consequently, as GFR declines, substances like urea and creatinine begin to accumulate in the bloodstream due to reduced renal clearance. This accumulation leads to a state referred to as azotemia, marked by elevated blood levels of these waste products, and highlights the efficiency loss of the kidneys in excreting waste. The kidney's inability to excrete sodium and water appropriately furthers complications, resulting in sodium and water retention. As we illustrate this process, we see an increase in extracellular fluid volume. This expansion leads to hypertension and edema, significant clinical signs of nephritic syndrome. The body's water and sodium retention causes an increase in extracellular fluid, resulting in elevated blood pressure and interstitial fluid accumulation, manifesting as edema. Notably, periorbital and facial edema may be particularly prominent, especially in the mornings, while dependent edema may occur in the lower limbs. As intravascular volume expands from sodium and water retention, blood pressure increases significantly, contributing to hypertension. This rise in pressure can lead to severe complications, including headaches, visual symptoms, and pulmonary edema, although these secondary manifestations ought to be viewed with caution. In severe cases of acute kidney injury, we witness a drastic decline in GFR, leading to oliguria and eventual azotemia. As renal dysfunction worsens, further complications arise, including hyperkalemia and metabolic acidosis. If uremia becomes severe, symptoms such as nausea, vomiting, confusion, and pericardial inflammation may develop, highlighting the seriousness of the syndrome. As we step back to view the entire pathophysiological cascade, we can summarize: immune-mediated glomerular injury leads to glomerular inflammation, which subsequently damages the filtration barrier. This results in RBC leakage, hematuria, dysmorphic RBCs, and casts, along with narrowing of capillary lumens. Ultimately, this leads to reduced GFR, oliguria, and azotemia, compounded by sodium and water retention, causing extracellular volume expansion, edema, and hypertension. In conclusion, acute nephritic syndrome manifests clinically as hematuria, oliguria, azotemia, hypertension, and edema. The primary mechanisms to remember are that inflammation causes hematuria and reduced GFR, which in turn leads to salt and water retention, resulting in oliguria, edema, and hypertension. This succinct understanding is crucial for medical professionals in diagnosing and treating this serious condition.